easier to find. Oh yeah, it's working. So
Sweet.
whenever you're ready, you can go ahead and get started.
Okay. All right. We'll go.
Sounds good.
Hi, Dr. Hightower. My name is Duncan Andrus, and I'm a student pharmacist. And our patient, Violet Nelson, is a 39-year-old female who's presenting with septic shock. And I was asked to recommend a treatment to improve the status of the patient's septic shock.
Okay.
So Violet has received, to give you some background, Violet has received norepinephrine and guideline recommended treatment based on the surviving sepsis guidelines. So she's already been given her antibiotics and fluid resuscitation. Um, and then there was an article that was done by ACCP that discusses IV hydrocortisone use versus IV vasopressin use in patients with septic shock. And this study was a multi-center retrospective observational study, and it was conducted on patients between the times of December 2015 and August 2021. And it was all patients who had received norepinephrine prior to the study drug initiation. And specifically on those two medications, the vasopressin was at a dose of 0.03 to 0.04 units per minute, and hydrocortisone was 200 or 300 milligrams per day. And that's the usual recommended dose for septic shock treatment. And the study it also included patients who had received at least 30 milliliters per kilogram of IV fluid bolus prior to the drug administration. And they were also patients who had received antibiotics for presumed septic shock and have a baseline lactate of greater than 2 millimoles per liter. The subjects were also excluded from the trial if they were pregnant, incarcerated, they received vasopressors or inotropes other than norepinephrine prior to the study, or they received mechanical circulatory support or had a history of glucocorticoid use in the last 6 months, or a couple of other exclusion criteria where if they had simultaneous initiation of the norepinephrine or they were using the vasopressin and the hydrocortisone with at the same time or within 6 hours. Um, and our patient, Violet Hansen, meets all of the inclusion criteria except one of them. One of the inclusion criteria was to give a fluid bolus of 30 milliliters per kilogram, and her fluid bolus was only 2 liters. To get to that 30 milliliters per kilogram, it would have had to be 2.7 liters. So she doesn't necessarily fit that one, but she doesn't meet any of the exclusion criteria, and she meets all the other inclusion criteria for this trial. So, um, and then looking at the primary outcome of the study, the primary outcome was 28-day mortality. And the results of the study significantly favored hydrocortisone to vasopressin in regards to the 28-day mortality. Before propensity score matching, 73.2% of the subjects on vasopressin had a 28-day mortality, while the subjects on hydrocortisone had a 42.2% 28-day mortality. So it's significantly higher in the vasopressin group. And then when they were propensity score matched, the results were similar with a score of 66.9% for vasopressin and 46.9% for hydrocortisone users. And some other outcomes that were included in the study were hemodynamic response, resolution of shock, recurrence of shock within 72 hours, 28-day ventilator-free days, and new renal replacement therapy initiation, ICU length of stay, and hospital length of stay. And in all of those categories, hydrocortisone was also favored with statistically significant values. So they all favored hydrocortisone. There was one that did not favor hydrocortisone, and that was the new renal replacement therapy, just because it didn't have a statistically significant value. And then the other one was recurrence of shock within 72 hours. Just wasn't statistically significant when propensity score matched. Um, and then none of the adverse effects came back statistically significant except for cardiac arrest, which also favored hydrocortisone, but only when it wasn't propensity score matched. And then the other adverse effects that were evaluated were hyperglycemia, hyponatremia, hypernatremia, and GI bleeding, and then bacteremia and fungemia. And none of those showed statistically significant either way. And then the study was also conducted in several states, including Michigan, Florida, and Alabama. I think those were actually the only 3 states that it was conducted in. And the study had a high number of older Caucasian male patients. However, there was other races and ages included, as well as female patients were included in this study. So my assessment of the article is that its strengths outweigh the weaknesses. And one of the weaknesses of the study is that it was a retrospective study. That's probably the biggest weakness of the study because it doesn't allow for the randomization and leaves room for bias in the study. One of the strengths that they used to counteract that is that they used propensity score matching to factor in the confounding variables that can kind of skew the study if they're not taken into account. And then another strength of the study is that it was conducted in 10 hospitals across 3 states. So the data is coming from lots of different hospitals in some different geographic regions. And so that adds to the external validity of the study. And another limitation of the study is that since it was retrospective, we just have to kind of assume that everyone participating in the study was trained to give adequate care and adequate sepsis treatment. With that said, since it was across multiple hospitals, there was some variation in care, so that also adds to the external validity of the study. Since the patient is a 39-year-old female, she doesn't fit necessarily the main demographic that was in this study. However, since there were females represented in the study and there was a lot of different ages and the external validity of the study was pretty good, I think that this does apply to our patient. And then the other thing was that fluid bolus being a little bit lower, but since she may have been excluded from the trial, but that shouldn't exclude her from this being a valid study to recommend treatment. So my recommendation would be to start the patient on IV hydrocortisone, specifically at a dose of 100 milligram IV bolus every 8 hours for 5 to 7 days. I would also consider tapering the dose when discontinuing it to avoid hemodynamic deterioration. And the patient should also be referred to physical therapy before they are discharged and referred to her PCP, her primary care provider, within a week of discharge. And then while she's in the ICU, her volume status should be monitored at least every hour using a central venous pressure. And her pulmonary artery occlusion pressure should also be monitored hourly, as well as her mean arterial pressure should be monitored hourly. And then she should also have a continuous pulse oximeter while she's in the ICU. And then her serum glucose, electrolytes, blood pressure, weight, and presence of infection should be monitored every hour. And her mental status should be monitored every 6 hours. And then a complete blood count and a complete metabolic panel, as well as a lactate level, should be done at least every 4 hours. And then to conclude, the recommendation would be that IV hydrocortisone bolus at a dose of 100 milligrams every 8 hours. And then did you have any questions or need help getting an order for that?
Yeah, I support that recommendation. If you want to submit the order, that'd be great.
Okay,
Appreciate your help.
have a good day.
You too. All right, you can stop the recording.
Do I click stop?